Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our series, which was developed for individuals who have suffered a concussion, their caregivers, as well as healthcare providers. Our sessions focus on various aspects of concussion and include an expert speaker presentation for our first half, and that's followed by a question and answer period for the remainder of the session. Just before I provide any further information, I'd just like to also acknowledge the Indigenous peoples of all the lands that we are on today. While we are meeting virtually, I would like to take a moment to acknowledge the importance of the lands which we all call home, to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. If you haven't been with us before, just to let you know, our webinar series takes place every other Tuesday evening from 6 to 7. And if you've missed any of the previous sessions, they are all archived and housed on the Canadian Concussion Center's website, so you're able to access those there. And I suspect Christian will probably be putting the link into the chat. Also, if you do have a question this evening, if you look to the bottom of your screen, you'll see that there's a Q&A. Please enter any questions for our speaker in the Q&A. If you're having any technical difficulties, please enter those into the chat and Christian will give you a hand. And yes, he's just posted the link for the previous webinars. Just before I introduce our speaker, we're just going to run our usual short poll just to gather information on who we have in our audience. I'll just give you a second to do that. And for this evening's session, I'm really pleased to welcome back Shaleen Sulway, who's going to be speaking tonight. Shaleen is the founding co-director of Vestibular Health. She is a physiotherapist who is passionate and extremely dedicated to helping patients with dizziness and balance disorders. Since 2010, Shaleen has been part of the multidisciplinary clinical team at the Hertz Clinic for Meniere's disease and vestibular dysfunction located at the University Health Network. Shaleen established the Hertz Vestibular Rehabilitation Program and to date has helped well over 1,000 patients with dizziness, offering one-on-one individualized assessments and treatments. Every week, Shaleen continues to do interdisciplinary assessments with doctors John Rutka and Paul Rinaldi, seeing some of the most complex dizzy patients from across the province. So with that, I'm going to turn it over to Shaleen.
Great. Thank you for the introduction, Leslie. So thank you everyone for joining. Our talk today is about vestibular physiotherapy as a treatment for dizziness after concussions. So a high percentage of people that are diagnosed with a concussion have symptoms, and these symptoms will usually resolve in the first 3 to 4 weeks. Now, if you're watching today and suffering symptoms after a concussion, or if you're a clinician that sees patients after a concussion, you can probably relate to some or all of these symptoms that are listed here. Now, symptoms of dizziness and balance, these are typically vestibular symptoms, and visual issues are quite common. And aside from being difficult to understand and treat, they often end up being interconnected. So what I will delve in over the next 30 minutes is helping you understand dizziness after concussions and its relation to the vestibular system. We'll review the anatomy of the vestibular system, review causes and symptoms of vestibular problems. We'll go over vestibular rehabilitation treatments for vertigo, for imbalance, and visual motion sensitivity, and then talk about some barriers to recovery. So dizziness is the second most common symptom after a concussion. It's second only to headache. So it is very common. And for those of you who have ever had it, it's a very disabling symptom. And depending on the research paper that you look at, symptoms of dizziness and vertigo occur in up to 80% of concussions. Now, we know that if dizziness is there early on, it's often linked to protracted recovery. In one particular study that was done at the University of Pittsburgh Medical Center, they looked at 107 football athletes, and they looked at 11 different symptoms, from loss of consciousness, amnesia, nausea, vomiting, concussion, visual symptoms, dizziness. And they found, out of all those 11 symptoms, dizziness at the time of injury was the only factor that predicted a protracted or delayed recovery, where it took longer than 21 days to recover. So what causes this dizziness? Most commonly, it's the vestibular system. And this vestibular system has two parts. One is in the inner ear, also known as the peripheral vestibular system, or it can be in the brain, known as the central vestibular system. And this is the parts of the brain that process those vestibular signals coming from the inner ear. And in some cases, of course, it can be a combination of the two. So let's take a look at the inner ear a little bit more closely, review the anatomy. We can start here. If you can follow my cursor, you've got the outer ear, you've got your ear canal and your eardrum. So that makes up the outer ear. Behind your eardrum is your middle ear space. And then one layer deeper than that is the inner ear. Now, the susceptibility of the inner ear to trauma is not surprising, since the entire inner ear structure is completely surrounded by the temporal bone, so it is subject to forces on the head. So let's look at this inner ear structure a little bit more closely. We have here 3 semicircular canals. They are oriented 90 degrees to one another, and each one has a different name: the horizontal canal, posterior canal, or anterior canal. And these canals are filled with fluid, and they respond to rotational movements of your head. So if I turn my head up and down or nod up and down, fluid moves, and that triggers my brain to realize that I've moved my head. Below here are our otolith organs. So here, just below, is the saccule. It senses linear acceleration. So if I'm sitting in a vehicle and the car suddenly accelerates or stops, that motion is sensed by my utricle. Sorry, I may have said that wrong. This is the utricle that we're looking at first. And then we have the saccule, which is the other gravity receptor, which senses gravity. So if you're falling in a roller coaster or dropping in an elevator, that is sensed by the saccule. So you've got your saccule and your utricle. And let's see how this vestibular system operates. So your inner ear sends information about the position of your head and how you're moving, which way is up, and how you're oriented. This information from the ear goes to the back of the brain, specifically the brainstem and the cerebellum. And from here, we have 2 different outputs. So these outputs are usually reflexes. The first one is the vestibular ocular reflex. This is the reflex that allows us to see the world clearly when our head is moving. And then the second reflex that comes out of the brain is the vestibular spinal reflex. This goes to all our postural muscles to allow us to be upright and balanced, and gives us our spatial orientation. So the 3 functions of your vestibular system are to be able to see the world clearly when you're moving. It's our internal Steadicam, provides us with posture and balance, and prevents us from falling over, and spatial orientation. So a concussion can result in abnormal functioning of any part of this vestibular system. So for instance, if there's trauma to the vestibular organs in the inner ear or the nerve, then what will happen is you'll have abnormal signals going from that part of the ear going into the brain. The other option is the brain could be injured. And if the brain is injured, then even if the ear is normal, the inner ear is normal, and the nerve is normal, the brain may not process that information coming from the ear properly. And if that information is inaccurate or asymmetric, or the brain thinks it's inaccurate, then the output will be inaccurate as well. And when things are inaccurate, then you have symptoms. And the symptoms that we classically see with vestibular problems are dizziness, vertigo, disequilibrium, and visual symptoms. So I'll talk about each of those and define each of those 4 symptoms. So the first one, dizziness. Dizziness is a very non-specific term. It can mean different things to different people. Dizziness itself is not a diagnosis, it's a symptom. So in our clinic, we usually don't accept when patients say, "I'm dizzy." We usually say to them, "Well, what do you mean by dizzy?" If you couldn't use that word, how would you describe your symptoms? And here are just a few list of words that I often hear: lightheaded, rocking, swaying. I feel like I'm floating, off balance, foggy, woozy, discombobulated, or spinning. Vertigo, that's another symptom. This is a very specific type of dizziness. This is the illusion that you or your environment are moving when you're actually not. Often it will have a rotational or a spinning component. That's what most people think of when you think of vertigo, but it doesn't always have to be that way. Sometimes it can be a tilting feeling, like you feel like the world is tilted. Sometimes it's a feeling like you're bobbing up and down or being pushed or pulled. And vertigo itself, it can be triggered. If it's triggered, often it could be position changes or head movements that can trigger it. Or the vertigo can be spontaneous, where you're sitting perfectly still and suddenly a vertigo spell happens. Vertigo, depending on the cause, can last seconds, it can last minutes or hours, and in some very rare cases, it can be constant. You can have other ear symptoms like tinnitus, fullness, or hearing loss, and it often is accompanied with nausea or vomiting. The third symptom is unsteadiness or disequilibrium. This is often accompanied with spatial disorientation. So what patients often say, I hear this all the time: people must think I'm drunk when I'm walking, or they feel instability when they're standing or moving. Usually the disequilibrium is worse with movement, especially if they move their head. Patients often feel worse in the dark or on uneven ground. And a lot of patients will say, I feel best and I feel my balance is normal if I'm sitting still. And then finally, there's visual symptoms that come with vestibular problems. And we usually like to categorize visual symptoms into two categories. So one could be related to an issue with the vestibular ocular reflex. So if patients have any loss of activity with this reflex, they complain of oscillopsia. And what oscillopsia is blurry vision when you move your head. So what patients will usually say, I move my head rapidly and I just feel like my eyes don't catch up. There's a bit of a lag or a delay. And when they're walking down the street, it feels as though the horizon is bobbing up and down. The second type of visual symptoms that we see is visual motion hypersensitivity. So this is intolerance for busy visual environments. This can happen with reading, with watching TV, particularly if there's a lot of panning of the camera. You'll see this with computers and phone screens or tablets, especially if they have to scroll. Large or narrow spaces can trigger this. Malls, grocery stores, airports, traffic, or being in crowds can trigger it as well. So we call this visual motion hypersensitivity. Now, what are some of the common vestibular causes of dizziness that can arise after a concussion? The top three that we typically see are benign paroxysmal positional vertigo. We know that as an acronym called BPPV. Vestibular hypofunction, where you have some loss of balance activity in one or both ears. Persistent postural perceptual dizziness, which I'll talk about. This is more of a persistent type of dizziness that lingers for months after. And then you can have other diagnoses: vestibular migraines, temporal bone fractures, labyrinthine concussions, post-traumatic endolymphatic hydrops or Meniere's disease. These generally are relatively rare, but definitely can occur after a concussion. So we'll focus on, for the purposes of our talk, the top three. So we'll start with BPPV. So this is the most common presentation of vertigo in adults around the world. Whether or not they've had a head injury or not, it still remains the most common presentation of vertigo. Now, under the age of 50, the most common cause is a head injury or a concussion. What we see with this condition is patients have vertigo lasting less than 60 seconds, and it can occur on a recurrent basis. Things that trigger it are changes in head position relative to gravity. So lying down, rolling over in bed, bending forward and coming back up, or even looking up. It rarely, or in fact will never occur if you're sitting perfectly still. Often with BPPV, you'll have associated nausea and vomiting. You can have imbalance, and the imbalance can last hours or days after an episode. You can develop motion sensitivity and often causes a lot of anxiety for patients. So in BPPV, what we see is the utricle. So the utricle is one of our gravity receptors, and you can see the utricle and the canals are connected. So all the canals have openings into the utricle. So as a result of a concussive force, what can happen is in the utricle, you have hair cells, and on top of the hair cells are small calcium carbonate crystals. So any kind of a concussive force, whether you hit your head or not, just the deceleration force that can happen with a fall, for instance, can cause these calcium crystals to become dislodged. And once they're dislodged, they will be floating around in the utricle. And usually what you have then is a sense of imbalance. But what can happen, and sometimes days or a few weeks after a concussion, if you move your head a certain way, these loose crystals can end up migrating accidentally into one of the three semicircular canals. And when that happens, when you move your head, now the fluid inside the canals move, the crystals also move, and this changes the canal's response to gravity. And when that happens, this will trigger two reflexes. One is the vestibular ocular reflex. And when that is triggered, you'll have vertigo. And clinically, we look at nystagmus or abnormal eye movements. And it also triggers the vestibular spinal reflex, which then leads to imbalance. So how we test for this, we usually for all patients coming in, this is a standard part of our neurological assessment, we do a Dix-Hallpike maneuver. So we have the patient sitting upright, and then we turn their head 45 degrees to one side, the side that we're testing, and then we lower the head down so that they're 30 degrees below the horizontal. And what we look for is there any movement of crystals in the balance canals? And if there is, the vestibular ocular reflex will trigger the eye movements, the abnormal eye movements. And depending on where those crystals are, you can see these three semicircular canals labeled in different colors. Each canal triggers a different set of eye muscles. So if crystals are here in this blue canal, what will happen is muscles on the inside and outside of your eye will activate and will make the eye move in a horizontal fashion. If you've got crystals in this red canal here, the posterior canal, then we see the superior rectus muscle activate, which pulls the eye upward and then in a counterclockwise or clockwise manner. So very important for us to watch the eyes to be able to determine where these crystals have migrated. And I'll show you an example of a recent patient I saw post-head injury. So here I am doing a Dix-Hallpike. I turn his head 45 degrees to the right and I lower him down. And once the head is settled in that position, we look at the eyes. And if you look at his eyes, hopefully there's no delay in the camera there, in the video feed, but you can see the eyes were beating. It only lasted about 10 to 15 seconds and then it settled down. So the way we call this direction of nystagmus is upbeating, torsional nystagmus to the right. So that immediately alerts me that the crystals are loose in the right posterior canal. And from there, once we figure out where these crystals are, we can do a treatment. Each canal gets its very own treatment. So this is the treatment for the posterior canal. We start with that head hanging. And if we see the nystagmus there, we proceed into the next position. So position D here, we rotate the head a further 90 degrees. We further then in the next position, rotate the head a further 90 degrees. With each 90-degree turn, we're trying to move the crystals closer and closer back into the utricle. And then when we finally sit the person up, the idea is the crystals are in the right position where they can fall back into the utricle. And usually this is pretty quick to be able to fix someone's vertigo. Now, if I do a Dix-Hallpike and I don't see nystagmus or I don't see any vertigo, we will test the other canals. So this is a test for, it's called the supine roll test, which tests for crystals in the horizontal canal. So you'll see with this patient here, I'm going to roll her on her left side and watch her eyes. So there is a horizontal nystagmus here. This is called left beating nystagmus. And when your horizontal canal is involved, doesn't matter which way you roll, whether it's right or left, both sides will bring on the dizziness. So I'll fast forward ahead here. We're going to roll her on her right side. And on her right side, I look for nystagmus again. And what we're looking for is the stronger nystagmus side. So here she's got right beating nystagmus, and it's definitely stronger, causing more symptoms for her. So the diagnosis here is right horizontal canal BPPV. And it usually lasts, as you can see, it's settling down in her case, so usually about 30 seconds or so, or less. So the treatment for this, I love the name of this treatment. This is called the barbecue roll. So you start here in position A, where we have the head rotated to the affected side. After about a minute, we move the head back to the middle, 90 degrees. Another minute later, we move the head a further 90 degrees. Another minute later, you turn the head a further 90 degrees so that the nose is pointing into the bed, and then we sit them up. And in the process of sitting up, the idea is the crystals will fall back into the utricle. We do have clinical practice guidelines that offer very explicit recommendations on how to assess and treat BPPV. This comes from extensive research and evidence. And the research shows that there is very strong evidence to support diagnostic assessments and treatment maneuvers. And there is an 80 to 90% success rate within 1 to 3 maneuvers. Now, a little bit of a caveat, BPPV due to head injury is a little bit more complex and difficult to treat. We find patients tend to require multiple treatments, tends to be bilateral on both sides, 3 times more likely that they will have crystals in multiple canals, and they have a higher chance of recurrence compared to someone that develops it without a head injury. So that's BPPV. The second most common thing I will see is vestibular hypofunction. So what that means is that you have loss of balance activity in one or both ears. Causes for this after a concussion could be a temporal bone fracture, injury to the canals, utricle or saccule, or the nerve itself. And symptoms are dizziness, vertigo, imbalance, and oscillopsia. And usually if it's because of an injury like this and you have sudden loss of balance activity, you will have vertigo and dizziness lasting hours to days before it slowly starts to settle. And the goal is, the treatment for this is not medications or surgery, it is purely exercise-based. So this is where vestibular rehabilitation becomes important. We provide exercises to teach the brain to compensate for the asymmetric vestibular signals. So first of all, we need to assess this condition to see if it's there. And the way to assess hypofunction is to assess the reflexes that come out of the ear. So the first one is your vestibular ocular reflex. So the way we assess this, so what I'm telling this patient is I want you to focus on a target in the distance. And while this patient is focusing on that target, I'm moving his head side to side slowly and then doing some very rapid ones. And I'm watching to see if his eyes remain on target. So here is a rapid head impulse to the left, and his eyes remain on target the whole time. Whereas when I move the head to the right side, there's a bit of a lag. And there's one last one, you might see it there. So there's a bit of a delay in that eye staying on target. So that is a very localizing test. It tells me that his right vestibular system is not functioning as well. The other thing we do when we do find this, we do training for the vestibular ocular reflex. It's quite effective. What I tell the patients is to maintain fixation on a target and start to move their head. So here I am telling this patient to look at a target, the letter X on the wall, and start moving your head as fast as you can, as long as the image remains in focus. And we start with a nice simple background, simple target, and then eventually move to moving targets, and then eventually move to complex targets as well. So it could be a checkerboard that I put in her hand instead. We have a clinical practice guideline on this as well, which recommends that patients need to do these exercises for 12 to 20 minutes a day. In the acute phase, 12 minutes. In the chronic phase, it could be as high as 20 minutes. The other thing we like to assess is the vestibular spinal reflex. So this basically is looking at balance. So we have a posturography machine in our clinic that allows us to really thoroughly assess balance. So we have them do 4 different tests, standing on a firm surface with their eyes open. And when you're doing that in the first test on the left here, this is assessing all balance senses. And there's 3 balance senses altogether: vision, your vestibular system, and your proprioception. So your vestibular system doesn't work in isolation. It needs the help of vision and proprioception to provide balance. So when we're assessing someone on firm surface with their eyes open, we're assessing all three senses. In the last one here, I'll jump to the bottom right. Here we have a patient standing on a compliant surface with their eyes closed. So now on a compliant surface, you can't feel your feet as accurately. Your eyes are closed, so vision has no part to play. So we're really just relying on that vestibular system. And these images that you're seeing represent sway patterns on the graph. So you can see in this patient, the vestibular system is her weakest link. She's got the most sway when her vestibular system is left on its own to balance. So we don't just assess standing balance, we also will look at walking assessments as well. So walking assessments are done with a little bit of a vestibular stimulation in mind. So we don't just have you walk straight or walk heel to toe. We want to have you walk and move your head side to side and see what happens to the balance. Or walk and do a rapid turn 180 degrees to one side or another, or walk with your eyes closed. So these are some of the things we would do. And if there is a deficit or a challenge, then a lot of your exercises will be targeting the vestibular system. We'll have you stand on a compliant surface and do exercises with your eyes closed. The third condition is a condition called persistent postural perceptual dizziness. This is a mouthful. We call it 3PD or PPPD for short. Symptoms with this condition are nearly constant dizziness, but of a non-spinning variety. So patients are either feeling constantly floaty or swaying or rocking. There's a sense of imbalance. And for you to have this diagnosis, it has to be present for more than 3 months. And typically, symptoms get worse with upright posture, with motion of yourself or motion in the environment, fatigue, and complex visual stimuli. So being in malls or grocery stores. So what happens here in this particular condition? Balance information comes from your eyes, your ears, and your feet, your proprioception. This all goes to the brain, and the brain signals your eyes and your body muscles to keep you balanced. Now in PPPD, what we end up seeing, or even before that, what we end up seeing is if there is a vestibular deficit, your vestibular system will send abnormal signals to your brain, which will then make you feel dizzy. Now, after some time, the brain will start to compensate, but sometimes not always in the right way. So it's a bit of a maladaptation. So what the brain will want to do here is ignore the vestibular inputs and perhaps shift the focus into another reliable sense. So here, what happens is the brain starts to rely on vision to control the balance instead of the inner ear. So now you're overusing vision to control your balance. And in some concussion studies, these are studies from over 20 years ago, they have seen this phenomenon where after a concussion, the brain relies more on visual cues for balance than an able-bodied population. And if you remove visual cues or have someone close their eyes, patients after a concussion have a hard time balancing. So in this condition, you basically are overutilizing or overprocessing visual information for balance. So you become dizzy with complex visual stimuli, with patterns or busy environments, and you also become sensitive to motion in your environment. What we typically see if we do a posturography assessment on these patients, we typically see that the two test conditions, this is on the right side of this graph, both of these test conditions involve closing the eyes. So the first one is standing on a firm surface with the eyes closed and then on a compliant surface with the eyes closed. We find these patients tend to have much higher sways in these settings rather than on the left-hand side where they have vision available to them. So this is a classic pattern I will see in my posturography assessment. What do we do with these patients that have this symptom? Well, we want to reweight the senses and have the brain rely on all three signals equally. Rely on the vestibular, the vision, and the proprioception. So how we do that is we first get the vestibular inputs working better, teach the brain how to use those vestibular inputs again. We down-regulate dependence on vision and get the proprioception to work even better. We also will start with habituation exercises where we start repeatedly exposing patients to provocative movement or things so that the brain can adapt and desensitize. And we also use de-escalation strategies to build a sense of control. So if dizziness starts to escalate, we don't let it escalate beyond a 3 out of 10. And then we use strategies to get the brain to control symptoms. So closing the eyes, grounding, breathing, cognitive reframing, and distraction. And we find with this condition, it's often associated with anxiety, catastrophizing, and fear and avoidance behaviors. So we do need to address that as well. So what is vestibular rehab? It's basically an exercise-based program delivered by specially trained physiotherapists with the goal of improving problems caused by these vestibular disorders. So our goal with treatment is to promote central compensation for the vestibular loss. So we want to recalibrate how the brain is interpreting vestibular signals. And when this happens, you will see a reduction in the vertigo and the dizziness, balance, mobility, and the confidence gets better, falls are reduced, and your visual symptoms get better as well. What therapy involves is a comprehensive assessment. It usually takes me about 90 minutes to do a full assessment on a patient. We understand the symptoms and the priorities. We do tests of inner ear and central vestibular function, look at balance and walking, and most importantly, come up with a diagnosis so that we can come up with a prognosis. Treatment is guided by the assessment and goals. They're very individualized and targeted. They are always active and exercise-based. In order for the brain to compensate, you have to move. And we focus on meaningful activities to improve function. And always patients are given a home exercise program. In my practice, I typically see patients every 2 to 4 weeks. So in between that time, I'm expecting them to do the work at home. All of our patients are told to walk for 30 minutes. That's a given. That's the only exercise that's standard across all my patients. Gradually, they're told to increase the intensity and the time. Many, many benefits to walking. If you talk to a neurologist, they'll give you their standpoint. From my standpoint, in a vestibular clinic, it facilitates vestibular stimulation and allows the brain to compare vision, vestibular, and proprioceptive inputs to recalibrate things. And it also improves growth factors, brain-derived neurotrophic factors, which help with plasticity, helps with mood, improves fitness. So many, the list goes on for why it's important to walk. So is vestibular rehabilitation effective? There are clinical practice guidelines and Cochrane reviews that show moderate to strong evidence for this type of therapy. Now, despite the good evidence, sometimes patients don't get better despite our best efforts. And this is something that was something we looked at about 10 years ago in our clinic to see what those barriers could be. And we found anxiety, panic, and catastrophization were big barriers to recovery. So it's a bit of a busy slide, but let me walk you through this. You can start with a concussion or an inner ear injury from that. Usually what that leads to is dizziness. Now, over time with adaptation, a lot of patients will recover and have no fears or avoidance behaviors. They move well, they adapt and recover back to normal. But then there's some patients that we find that go on to developing catastrophizing or absolute thinking. They develop fear and avoidance behaviors. This triggers anxiety and depression, and then you are stuck in a vicious cycle. The inner ear problem and concussion injury may have come and gone, but you are now stuck in this cycle, and that's what can hold some patients back. So in our clinic, Dr. Pothier, who used to work with us, developed this model. You can have two patients, patient A that has a pretty significant injury, minimal catastrophization, they have a certain set of symptoms. Patient B, on the other hand, has a small injury and significant catastrophization. And that adds up to the same amount of symptoms as patient A. So both patients are suffering equally, but each one needs a different focus. So one needs, patient A, we need to focus on the injury itself. Patient B, we need to focus on the catastrophization to better serve their needs. So what we developed in our clinic is a dizziness catastrophization scale. This is a scale that was published on, it's readily available out there. We give this to all of our patients before we see them. And if we find the numbers are very high on the scale, they're scoring 50 out of 52, then maybe vestibular rehabilitation is not the right thing for them at that time. We may consider having our vestibular nurse or vestibular psychiatrist intervene first. So what to do if you have dizziness, I'll just wrap up here. You can consider ENT consultation, or you can also consider an assessment with a vestibular rehabilitation physiotherapist, or you can do both as well. So just to summarize, dizziness is a common symptom after concussions, often accompanied by balance impairments and visual symptoms. The initial presentation of dizziness is an important clinical finding and should be evaluated further with vestibular imbalance testing. BPPV is the most common inner ear disorder and responds quite well to treatment. And if patients are not improving, we need to recognize and address either anxiety or catastrophization, because that can delay recovery. And speak to your doctor if you have dizziness, or you can always give us a short phone. You can have a short phone consultation with us to see if vestibular physiotherapy is right for your symptoms. Thank you very much for your attention.
Great. Thank you so much, Shaleen. That was excellent. I am just going
Should I
to,
stop this screen share here?
um,
Or leave it there?
I think you can leave it there.
Perfect. Okay.
Oh, or maybe, I don't know if that was Christian. I think we're okay.
Okay.
Yeah,
Sounds
just leave it up there. That's great. So we've got a few questions already.
okay.
And the first one from Joanne, she's asking, why do certain vestibular exercises cause migraines?
That's a good question. Usually I would not think of vestibular exercises causing migraines. Certainly migraines can cause vestibular symptoms. So we usually see it in that way, but I usually don't see that where the vestibular exercises causes migraines.
Okay, thank you. I have had numerous concussions and my balance is horrible. I don't have insurance and am on ODSP, so I can't afford vestibular rehab. Is there anything that I can do to learn to do some of these things myself?
Absolutely. Yeah, that's a tough situation, especially with physiotherapy not being OHIP funded. There are some OHIP funded clinics out there, but not a lot of physiotherapists. When they come out of school, physiotherapists at the entry to level practice don't have the vestibular knowledge. And I don't know of any OHIP funded practices that offer that. I would say one of two things. If you can afford a single session, often just getting a diagnosis is really important and learning the exercises that are specific to that diagnosis. And then you go away with that. I do that for so many patients where they'll just come in once. I'll give them a set of exercises over a series of number of weeks and let them work with that, just being conscious of finances. But the other strategy would be just being active. The life itself, as we're active, as we're moving, that's one giant vestibular activity. And that's a better way to me to stimulate that vestibular system rather than sometimes doing specific exercises like standing on one leg. So if you can emulate activities through life, it's much better to actually practice going into a grocery store where you might be a little bit triggered and slowly start to acclimatize yourself to that. And sometimes you can also pick your own exercises, pick things that are moderately bothersome for you and slowly start to attempt them. But don't push to the point where you have such severe symptoms where you can't function. Maybe you just push a little bit, you poke the symptoms a little bit, back off, take some breaths, relax, and then try it again a little bit later and slowly start to build up your tolerance. So that would be another strategy. And walking. I can't tell you enough how many patients we see that were so symptomatic after a concussion for months. And they'll say, I just didn't move. But as soon as I started walking, things started to feel better. So I would think that's my one go-to thing. Just start to move, but stay below the threshold of symptoms. I hope that helps.
That's great. Thank you. Do vestibular vision issues result in screen-related headaches? So another headache one. If so, should you be getting a vestibular assessment or a neurooptometry assessment if you have post-concussion symptoms, primarily?
So I would say definitely we see that in our patient population because I see concussion patients and I see patients that don't have concussions. And anytime there's any level of vestibular involvement, we see these same visual symptoms that our post-concussion patients have. So many of my patients that don't have concussions are sensitive to screens, can't scroll on their phones, are very sensitive to being in busy environments where there's a lot of movement, watching traffic. And usually it's because of a vestibular issue. And that's led to vision overcompensating. And if vision is doing all the work for balance, well, how is it supposed to focus in these busy, complex environments? Or with the flicker of a screen, every time you look at a computer screen 60 times a second, you're seeing a different image. So that's a lot to process, especially if your vision's busy doing something else. So my go-to would definitely be starting with a vestibular assessment to see if there is any involvement there. And certainly we do see headaches, not necessarily migraines, but headaches or strain being triggered after being on a computer.
Great, thank you. Next question. Apologies if this was mentioned earlier, but do you consider tinnitus part of this system?
Yeah, so we do see tinnitus with inner ear issues. Tinnitus comes from the cochlea. So this is the organ inside the inner ear, still in the inner ear, but it's not the balance organs, it's the hearing organ, and that can generate tinnitus. We see tinnitus with some vestibular problems like Meniere's disease. So with Meniere's disease, we see attacks of dizziness, vertigo, imbalance, but also tinnitus, hearing loss, hearing fluctuation. Typically with tinnitus, a lot of times what tinnitus is the brain filling in missing information for hearing loss. So our brain is getting a certain amount of stimulation from our hearing organ. And when that's missing, and that can happen from a concussion, you can lose hearing, your brain will take that missing information and substitute that with tinnitus. So usually very important to start with a hearing test to see if there's any hearing loss. And often patients that do end up getting hearing aids or those hearing aids can be built with tinnitus masking devices. But that's if there's hearing loss.
Okay, great. Our next question. Every time I bump my head, I end up with tinnitus. Thankfully, just for a few days or so. What causes this?
That's a good question. I don't know, a little bit outside of my scope. I know I focus on the inner ear, but I'm focused on the vestibular organ rather than the hearing organ. It could be, who knows, it could be something to do with your brain having compensated. When a lot of people have tinnitus, the brain can learn to compensate for it and put it in the background. And we often see this, I relate this to vestibular symptoms. Usually when I work with my vestibular patients, I teach them exercises, the brain learns to compensate. Problem's still there, but the brain's compensated and they don't notice the symptoms anymore. But we usually find any kind of a head injury or bump to the head can sometimes cause decompensation. So I wonder if there's something to do with that, where your brain has compensated, been able to switch the tinnitus off or put it in the background. And if you hit your head, there could be a decompensation, but I would say I'm not probably not qualified to answer any further.
Okay, great. Thanks, Shaleen. Next question. Dizziness is still one of my main symptoms at 8 months post-injury. Sounds like they had a physiotherapist, didn't do the BPPV test until about 6 months post, and it wasn't quite done correctly based on what was shared here. Would this impact the results? I've been doing head movement and focus exercises since and getting triggered from such movements. Sorry, I have deep.
Yeah, no, that's sorry, that sounds like a very tough experience that you're going through. Very hard for me to answer that without having done an assessment. I think I mentioned this earlier. I think the most important thing when it comes to a vestibular assessment is the diagnosis. What is the diagnosis? And from that, you can come up with very specific targeted exercises. Dizziness itself is not a diagnosis, it's a symptom, but what is generating that symptom? And I think until you know the answer to that, it's hard to answer this question, and it does take a very thorough assessment to figure that out.
Okay, thank you. Is it common for a person who has had a concussion to regress or stop making progress after vestibular training? If this happens, what would you recommend? I am so much better than before doing physiotherapy, but it seems like I am often just a little bit dizzy. And they indicate they don't think they're catastrophizing.
Good. Sorry, ask me the beginning of that question again.
Yeah, is it common? So after someone has gone through vestibular training,
Yeah.
does it happen that people will sort of go back? Will they get worse?
Will they get worse? So yeah, so when I'm discharging any patient, I will definitely tell them that you've compensated, your brain's figured out what to do, but it is possible you can regress and go backwards. And I usually say the number one reason for regression would be any kind of a major illness. So let's say you're in bed for a couple of weeks with something or a really bad flu, that can cause regression. Certainly another head injury can cause regression as well. And I know this person, a particular person, is not catastrophizing, but emotional decompensation is something we often see in the clinic. So major anxiety or depression can result and that can cause symptoms to go backwards as well. So those are usually my top three. I did see over COVID as well, many patients also tended to go backwards, and I attribute that to lack of basically disuse. Patients were not going out, some patients were not going out, not moving. And if you're not moving, you're just not generating those signals between the inner ear and the brain to maintain that level of compensation. But the good news is, if your brain's been able to compensate once, it can do it again. So it's a matter of maybe picking up those exercises again, being a little bit more active to see if your brain can compensate again.
Great. Does the 12 to 20 minutes of exercise have to be done all at once, or can you break it up throughout the day?
Excellent question. It absolutely cannot be done all at once. And the reason for that is we're trying to train the brain, and repetition is the key to neuroplasticity. So I usually would say to a patient, do this exercise for a minute, and then do the second exercise a few minutes later, and do that 4 to 5 times a day. And sometimes it'll be more. It might be 3 minutes worth of exercise, but again, a minute at a time, so that we have lots of repetition and we feed the brain that stimulation multiple times a day. It does take thousands of repetitions, separate repetitions, for the brain to change, to rewire that brain.
Great. Okay, thank you. Do you have any experience with a vestibular imbalance along with binocular vision syndrome? Sounds like after a motor vehicle accident with persistent symptoms. I think that's what they're asking.
Yeah, so yes, absolutely. One of the things that we assess when we do a vestibular examination is a very thorough oculomotor examination. I'm also very lucky in our clinic. We work with a neuro-ophthalmologist as well, where we do look at monocular, binocular vision, convergence issues as well. Yes, those things absolutely can arise. You also have to look at it in the context of what was the situation with the eyes beforehand. And we take that into consideration, absolutely, when we're doing our exercises.
Great. After someone has had a traumatic brain injury, how long would you recommend waiting for dizziness to resolve before you would actually start doing vestibular therapy?
Yeah, so I would say generally most people, some studies say as high as 80%, will resolve within 3 to 4 weeks. Now, if you're specifically having position-triggered vertigo, which is the most common thing, where you lie down, bend over, roll over, and the room is spinning, that can be dealt with right away, and probably should be dealt with right away, because that's something very easy to identify and very easy to fix. But if it's generalized dizziness accompanied with other symptoms like headaches, light sensitivity, visual sensitivities, you can watch it. But usually by about 3 weeks, I would definitely consider, if symptoms are not resolving, to be assessed, not just from vestibular rehab standpoint, but more of a thorough medical assessment as well, looking at all the different symptoms.
Okay, great. We've got a question. Would other aerobic exercises outside of walking, such as using a stationary bike, would that be helpful, or they're asking, is walking better?
So I think for me, my opinion, walking trumps all those other exercises. I think from a general concussion standpoint, any aerobic exercise is fantastic. And that's usually where we would start. If it was general concussion symptoms, you would start on a stationary bike because that's usually less triggering. But when it specifically comes to the vestibular system, we've got three signals. We've got vision, vestibular, and proprioception. And if we can get all three systems to work together and send the same message to the brain, that is ideal. And that happens with walking. So when I'm walking, my vision says I'm moving because the world is going past me. I can feel my feet moving on the ground and my vestibular system is sensing acceleration. If you put me on a treadmill, on the other hand, what's going to happen is my vestibular system says, yes, I'm moving. My feet are sensing that motion, but my eyes say, no, we're not moving. We're in a stationary environment. And that creates sensory conflict. And that's not what we're looking for. There's already some conflict with the inner ear. Now, we don't want all three systems not agreeing. So that's why I would pick walking. The second reason for walking, if there's a vestibular issue, then there's a balance problem as well. It's not just a visual thing, there's balance issues. Sitting on a bike is not challenging your balance, in my opinion. You got to get up and move. And especially if you can't handle too much walking outside, you can do it in hallways or something less stimulating. But walking outside is such a great exercise because you're not just moving and challenging your balance, you're also having to deal with visual stimulation. You're dealing with wind resistance, people having to navigate around obstacles. So it's just much more intensive, even though it sounds like such a simple task going for a walk.
Mhm. Great, thank you. And will using a walker or walking poles help with vestibular dysfunction?
Yeah, my go-to would, if you can safely use walking poles, absolutely. First of all, if there is any risk of falls, yes to either one of those. We want to minimize any risk for falling. So use a walker, cane, or poles. But poles, I find fantastic. Poles, when you're using poles correctly, you are actually using more than 90% of all the muscles in your body. So it's actually a better workout. Whereas with a walker, or let's say you're even holding a shopping cart in a grocery store, that cart is doing a lot of that work for you. So you can lean on it, you can walk and not challenge your balance. Whereas with the poles, you are challenging your coordination, you're challenging your balance, and you're working all the muscles in your body. So you're getting a better workout, aerobic workout as well. So hands down, if you can handle poles, I would pick that.
Great, okay, thank you. Before my concussion about 10 years ago, I could drive and at the same time look around, but still stay on the straight and narrow. Now I find that I can't look around at all, and then drift to the opposite direction. In other words, if I look at something to the right, I find that I'm moving off to the left. I did go through vestibular therapy and it was very helpful. This seems to be a residual side effect of my concussion, which was quite severe. I don't know if you've.
Yeah, so it still sounds like if your head is moving and it is sending messages to your brain to deviate to another side, it sounds like your brain has not fully compensated for that vestibular loss, in my opinion. And there's ways through assessments we can see that. But yeah, if keeping the head steady and you're fine, and suddenly you move your head, now you're activating your vestibular system. And that, if it's sending asymmetric signals, that can absolutely do that. You can deviate while walking or driving. So I would just have perhaps have another reassessment to see, have you fully compensated for that vestibular loss? Or are there more exercises that can be done to further promote compensation for this remaining residual symptom?
Okay, thank you. The next question I think what they're saying is I have post-concussion persistent symptoms, and I exercise doing cardio, walking slow, and cycling, it sounds like. I think they're saying they close their eyes when they're walking, presumably just for short bits of time. They're wanting to know whether this is a good idea. Is that a helpful thing to do?
It can be helpful, and that's where the assessment and diagnosis comes in. are you visually oversensitive? Like, are you visually dependent for your balance? And if that's the case, that there is dominance on vision for balance, yes, absolutely. My advice would be do more things with your eyes closed so that we can down train this overdependency on vision and get the other senses working better. Now, is it a safe thing to walk down the street with your eyes closed? Well, I will let you judge that. Usually what I tell patients to do, because that is an exercise that I will give patients, is I'll get them to put a finger on the wall just lightly and walk in their hallway for a set number of steps. So if it's a 15-step hallway, walk for 10 steps with your eyes closed and start to do that. And then do other things as well with your eyes closed when washing your hands, brushing your teeth. Standing in line, close your eyes and down train visual dependency. Again, if that's the correct diagnosis. But certainly closing the eyes will force the other two systems, your vestibular system and proprioception, to work more. So that definitely is a good thing.
Okay, great, thank you. Do you find noise or overall stimulation can also create dizziness in people with concussion?
You said noise or overall stimulation?
Yeah, I guess if they're in a stimulating environment, maybe lots going on or very noisy.
Yeah, so noise can with certain inner ear conditions. So if you have post-traumatic superior canal dehiscence, or something happened to the stapedius tendon in your ear, which dampens sound, yes, absolutely, that can trigger symptoms. But if you're in a noisy environment, what typically I would think is it's the visual stimulation of that environment that's causing more of the symptoms. So busy environments, there's just a lot to process visually. And if your vision is doing the bulk of the work to balance you, yes, you will feel dizziness in that environment.
Great.
The other thing, maybe I'll just, Leslie, add to that,
Yeah.
sometimes if there's post-traumatic migraines, post-concussive migraines, that also has light and sound sensitivity that could be associated with that as well. So that could be an overlapping symptom, especially if it's a vestibular type of migraine. So if you suffer from vestibular migraines, you can have headaches with dizziness as well. And if there is light or sound sensitivity, that could trigger that pathway. So that could be another source of symptoms.
Okay, great. Is dizziness while reading a vestibular issue? Sounds like they're many years post-concussion.
It can be. Again, what I would do with someone like that, first do a oculomotor assessment, and that can be done by a neuro-ophthalmologist or an ophthalmologist. Look at how the eyes move. Are the eyes able to smoothly track across a page? Are they able to go to the end of the page and jump back? So these are basically pursuit type eye movements or saccadic eye movements. So you want to look at that. Because if there's any deficits there, certainly that can trigger symptoms. And if all of that is completely normal, then yes, I would look at again, the overutilization of vision due to an underlying vestibular issue or an underlying vestibular ocular reflex issue and see if that could be an issue.
Okay, great, thank you. So we've got a lot of questions tonight, and I know we just have a few minutes left. How can you tell if a physiotherapist is trained in vestibular rehabilitation?
Excellent question. So when you graduate from most universities, when I graduated, it's been a while for me. There was absolutely no mention of the vestibular system as part of our program. So everything I've had to do has been postgraduate training. It's still, unfortunately, 23 years later, it's still the case. Most physiotherapists come out of school without any training in vestibular or dizziness. There is a competency-based course that is run out of Emory University in the States. They offer a very intensive course with experts in the field. And then there is a website out there as well. It's called the Vestibular Disorders Association. If you go to vestibular.org, usually you can see all the therapists in North America that offer vestibular rehabilitation. You can read their profiles and find out more. So I would encourage you to read profiles. You can also ask your doctor if they've sent patients to someone that is where they've had good results. And then also calling the physiotherapist as well and asking them about their practice and how much dizziness that you see, what kind of volumes you have. The more volume you have in something, the better you tend to get. So that might be another strategy as well.
Okay, great, thank you. When you train VOR, how do you progress? Each step should be symptom-free before you move on to the next step, they're asking. How much symptom provocation is acceptable in each exercise?
So usually my rule of thumb is from a symptom provocation standpoint, within 15 minutes or so, that dizziness should settle completely and should not linger in any way beyond that. And if it's lasting longer than 15 minutes, then I would reduce the intensity. So usual instruction is do the exercise for a minute. Well, maybe we need to start with 30 seconds and see how you do with that. But that's usually not my measure of progression. My measure of progression is speed. So I will watch a patient do their exercise, shake their head back and forth, and the instruction is move as fast as you can as long as the image is clear and not moving. If it's blurring, then slow down, and I measure those head movements in a visit. So let's say they move their head 60 times in a minute and still maintain stable focus. Well, the progression, once they hit the ability to be able to do 120 head shakes per minute, that's where the VOR, is working well. Then you progress the exercise. And that exercise progression could be a moving target that they have to follow, or a complex target. Different progressions that come with VOR exercises, but usually my rule of thumb is based on speed.
Okay, great. Well, maybe just try and stick in one or two more questions if you're okay with that.
I'm good with that.
Okay, Kathy's asking, it says this sounds complex. So has a traumatic brain injury, concussion, BPPV, vestibular migraines, tinnitus, and long COVID. Everything was improving. It sounds like they then saw an oral surgeon and there was some sort of whiplash injury, they're indicating. Now when they get the Epley maneuver, the crystals don't stay put longer than a few hours. Any suggestions? I also can't walk very far due to long COVID.
Right. Well, it sounds like if the crystals are not staying put and they're coming out, well, that's just stirring things constantly, and that can prevent you from getting better if the problem is constantly fluctuating. Without having seen you, it's hard to advise. But my question is, why are those crystals not staying in place? Some people are conservative when it comes to post-treatment precautions. So one of the things we like to do, and the evidence is mixed on this, but for someone like you where crystals keep coming out once you put them back into the utricle, we want to follow precautions for a couple of days. I would say sleep on 2 pillows, keep the head upright, because those crystals can't come out unless the head is extended back. Sleep upright for a couple of days and do not lie on the affected side. So if it's your right ear, if you lie on that right side, well, that creates such a perfect opportunity for gravity to pull those crystals out. So lying on the opposite side and sleeping upright. And there are other reasons why patients get recurrences. We know recurrences are high post concussion, but sometimes there are other systemic reasons why crystals won't stay put. There is a lot of evidence in the research that low vitamin D levels can cause frequent recurrences. And I would say if you've had 5 or 6 maneuvers, things are not getting well, things are not getting better, then it may be time to see an ENT if you haven't done so already, because there are surgical options available as well. Where it's a pretty straightforward surgery where they can go in and block, it's called a posterior canal occlusion surgery. And the surgeon will block the semicircular canal, and that will stop all crystals from moving. So that could be another option as well. So there's different options, but I would maybe consult with an ENT on that.
Okay, that's great. Okay, I'm going to ask one more question. And just there was a question about recording, and yes, tonight's presentation is recorded and it will go up on our website. So comment, excellent presentation. How do you differentiate dizziness between or vestibular symptoms from the top 3 most common post-concussion conditions that you listed versus vestibular migraine versus proprioceptive contributors or dysfunction?
I would say that comes with a 90-minute assessment. We are so thorough with looking at every part of that inner ear, looking at every contributor to balance, looking at proprioception and how that contributes to balance, looking at the vestibular inputs, visual inputs. I'm really lucky in my clinic. We've got lots of great technology to be able to do that. And sometimes, so usually I would say even before the assessment, what I should say is I do spend at least 30 to 45 minutes on a history. And most inner ear problems, and Dr. Rutka, who I work with, who I think is speaking next month, would say this as well, you should be able to come up with that diagnosis from the history alone. So our history is extremely specific, very detailed. So that can last 45 minutes and then a very thorough assessment. And every now and again, I may get stumped. And that's the beauty of vestibular function tests. We actually have a lab down the hall at our hospital at Toronto General where they do up to 4 hours of inner ear testing. So when in doubt, we can send patients for further testing as well. And when we still can't solve things, again, the beauty of my clinic, we're a multidisciplinary clinic. So we have access to the ENT doctors, neurologists, psychiatrists, and that's where a multidisciplinary team becomes very important when you can't figure things out. But for the vast majority, a good, solid assessment should help us narrow down those different diagnoses that I mentioned.
Okay, that's excellent. Thank you so much, Shaleen. Unfortunately, we're not going to be able to get to any more questions. Thank you for the great presentation and answering all of these questions. I would just remind you, there will be a survey that comes your way. So if you have a couple of minutes, please complete the survey, provide any feedback that you have. But also, if you didn't get a question answered, if you want to put the question in there, and just be sure to also provide your email address because they do come in anonymously. So you could, if you ask the question and don't provide a contact, we're not able to get back to you. So you could include it there. Just to, you can see on the screen, we're going to have Dr. Carmela Tartaglia back with us in 2 weeks. And she is going to be talking about concussion and invisible brain injury with consequences. So thank you again, Shaleen, really appreciate you being with us tonight and hope everyone has a good evening. Take care.